Welcome to Health is Number One podcast. I'm your host, Dr. Craig Wax, family physician. Hope all is well with you. We're talking about COVID-19 testing today. Everybody's screaming about testing, and how will the human race survive without testing, and what will testing tell us? It's important to understand testing. So we have our special guest expert here today, who is Dr. Ryan Cole, who's a pathologist from Idaho, and he's with us to help demystify testing and help us understand what it can do and what it can't do. Welcome, Dr. Cole.
Good morning, Dr. Wax. Thanks so much for the opportunity to share with you and your patients. And I'm happy to answer any questions you may have. Just by way of background, I'm an anatomic, clinical, and dermatopathologist and surgical pathologist trained at the Mayo Clinic. And so I've had the opportunity to see about 350,000 patients in my career through the laboratory. So I'm here to answer all the questions you may have concerning all these different types of testings and the confusion that's out there, and I'm happy to clear it up for you.
Well, thank you very much. It's very, very important. As I said in the intro, that politicians and media people or even network hosts on networks are yelling about testing. The whole human race depends on testing. So please help us understand a little bit more about what testing is out there, what it can do, and what it can't do.
Certainly. So the important thing to understand is a test of any sort for this virus or for any other virus or pathogen for that matter, a test is a snapshot in time. So at first, when the outbreak happened around the world, we were looking at how do we immediately identify the virus itself? And the test that everybody heard about at first was the brain scraping, stick that nasal swab way back in the nose and tickle very uncomfortably so. And what that test does is it's looking for particles of virus itself. So the doctor will take that swab. And now there's a few other ways we can do that. Now, you don't necessarily have to have that uncomfortable procedure, but that test, it's called an RT-PCR test. A piece of the RNA, this is an RNA virus, so the nucleic acid, the little molecules that make up this virus, basically we get those on the swab and then we take them to the laboratory and we have these special little primers, and then we can tell how much virus is present. So that's the first kind of test. That test is a fantastic test when virus is present. Here's the challenge. You can do a swab, and if there's not enough virus there, you may get a false negative result, meaning it's there, but the test didn't detect it. And what we find is there's usually a window of time within the illness when that test is sensitive enough or enough virus is present. So you have this about 2-week window, 10 to 14 days, in which really the best window for detection is for that particular type of test.
What kind of test checks for when virus is actually present? It has to be present in amounts that are detectable. And my understanding is that's about 8 to 14 days into the illness that perhaps it misses the first week.
Yeah, that's correct. The average day to illness post-exposure in North America, we're finding is about 5 to 6 days. So you can detect it as early as those first days of symptoms, and usually exactly how you pointed out to about day 14 post-exposure. So about a 2-week window. And that's the drawback to this test. In some of the early studies, we were only finding maybe 70% of patients would have virus present on that swab type test, even though the virus was still there.
So 30% of patients might get missed, and perhaps more in the earlier part of that illness.
Unfortunately so. And that's where we end up with the opportunity for other type of testing modalities, which I'm guessing you might ask me about here.
But please do. The next testing modality is?
The blood. So because the virus itself can be missed so many times, we have to look for, is the body reacting to the virus? And in that case, now we can take a sample of the patient's blood and we can do a blood draw, and your body produces an antibody. So it's against the virus, and it's your blood's little soldiers that will bind or glom onto the virus and help your other blood cells clear it out. So those antibodies, there are two types that we particularly look for in viral testing. You have an early one, an IgM, think M for mean or malicious. That's the early antibody that appears in the early process of infection. And we can usually detect those as early as day 5 or 6. And by about day 14, almost 100% of patients will show that IgM antibody. And then we have an overlap period with another antibody called your IgG, your good or gone or good to go. That's kind of the way I try to remember it. And so your IgG antibody starts to appear at about day 14 of the illness and peaks up around day 28 or so. And so we take a sample of the patient's blood, and there's a lot of different ways we can look for antibodies in the laboratory. One of the tests we're running in my laboratory for the IgG is 100% specific and 99.91% sensitive. So diagnostic accuracy is about 99.99% for COVID-19 itself. And there's some other tests. There's one called immunoflow assay, and it's almost like a little pregnancy test where you take some of the patient's serum, their blood, you put it on this little strip. There's a control strip on there like there is on a pregnancy test. And so those tests, they can be in the high 90s for accuracy, and those are very useful as a screening tool. And there's one other test we use, which is called an enzyme-linked immunosorbent assay. ELISA is how we remember it in the lab. And that ELISA test, yeah, and that one's very specific to the antibody itself. And the sensitivities are very good as well. So we have multiple modalities for finding these antibodies and then telling whether or not they're present. And the important thing with the antibody testing is if we have a patient that was missed on that window of PCR, if you're in that early stage and we find your IgM antibody and we've missed you by PCR, we can still catch you in that early phase of infection, where when you only have IgM, you're missed on PCR, you may still be in that early shedding phase where you have virus present, and we can detect your reaction in your blood where we were unable to find the virus, in your nose or throat.
Thank you, Dr. Cole, for your explanation. That was excellent. To make it straightforward and simple, there's the testing that is like the nasal swab or pharyngeal swab testing that is a PCR type of test. And that basically tests to see if pieces of the virus or bacteria are still around and are in enough amounts to be detected. The other type of testing that you referred to was the serological type of testing. Gosh, that's big word stuff. Having said that, it has to do with the blood, and it looks for antibodies, which are our own little bullets or arrows that our body makes when it sees a foreign pathogen and it mounts a defense. Some of them are longer term. IgM comes first and IgG comes second. How long do they last? How reliable are they? And are there people that just don't form IgGs no matter what?
Good question, Dr. Wax. The antibodies, like you had mentioned, these little soldiers that come out and attack the virus or bind to the virus, those IgM antibodies, they can appear early in the illness. And we have to consider that this virus has only been around the world for, 4 or 5 months now. So we're still trying to figure out how long do we really have immunity. And in some patients, if their immune system is weak, we're seeing that good antibody drop off, drift away. So we're still studying that around the world and really trying to figure out how long are we going to be immune to this virus. In a lot of patients, we're getting really good levels, and that antibody, that IgG, we can actually take the plasma from those individuals, transfuse that into other sick patients and make them better. So having antibodies is a good thing. It means you're prepared to face the virus again if it ever comes back. The challenge is the immune system of every individual, and how long do we hold on to those antibodies?
Are there people that never form IgGs or don't have a lasting response, and what's their role? Because when you talk about testing, testing could be used, by government, employers, communities to determine potential for immunity, but it's not a perfect system.
Excellent point, Dr. Wax. It is not a perfect system. And interestingly, a lot depends on how much virus the patient had on first exposure. So from the laboratory side, what we are seeing is some patients will mount a little bit of a response and it will taper off. And in your immune system, you may have a lot of what are called natural killer cells in your circulation, and that's your innate immune response. And so they have, your macrophage cells that are like your little Pac-Man cells. When the virus comes in, they'll grab it, and then this natural killer cell comes in, throws a hand grenade, and blows that cell up. So that's your innate immune system. And so what we're seeing in kids, well, why are kids not getting sick like adults are? Well, their innate immune system is so much stronger to this particular virus that they're clearing it before anyone gets sick. And so we're not seeing a big antibody response because that first response of their immune system is strong enough to clear it before you even have to form an antibody response. But some people have a super strong immune system up front, clear the virus right away. And if they see it again, they may form a little bit of an antibody response or they may not. So
maybe we can summarize the two major types of testing and talk about the role for both, because lots of people in the media and politics are calling for a huge role for testing in major populations as opposed to individuals.
Yes, you're right. And so the PCR, the acute test looking for the viral particle, that's very important in the sick patient setting. Understanding, have I been exposed over the long term? That's the blood, the serology, the antibody testing. So if you're acutely sick, or if a doctor's trying to, clear you to come in for a surgical procedure, they may want to see if virus is present, and they'll do that acute PCR type test. If they want to see whether you've already been sick or through it, then we can check your antibodies. So there's a point in time where it's relevant to look for the virus particle itself. And both as an individual and as a population, we want to see how many of us have been through the virus so far. And that's what we can use for the antibody testing. So it gives us statistics as a population, but it can also tell you individually, hey, gosh, I think I had this weird illness a month ago or 5 weeks ago. Was it COVID-19? And we're able to tell through the blood and your response to that a high percentage of the time that, yes, you were exposed and you were sick with that.
That is a great review. Thank you. If you wouldn't mind helping us understand the role for testing. Is it for individuals? Is it for populations? Is it for workplaces? How do you see that working, risks and benefits wise?
Yeah, I appreciate the point about the workplace challenge, because who's going to, have to wear a wristband or a card? I don't like this concept. If you have a strong immune system and you have a little bit of an antibody response, you should be good to go. And eventually we will have a herd immunity when when enough of us have been exposed to sick that the virus won't be able to run rampant through our population. So that antibody, that serology test, it's good both for the individual to know and put yourself at ease. Yes, I've been exposed. Yes, I've had it. Potentially I'm immune now. And or, as we go forward into society, if a high percentage of us have been through the virus, now the virus really can't overrun us as a population.
That's important. Herd immunity cannot be understated, because we've developed herd immunity to all of the things that have challenged humans' existence on Earth. In fact, we've even stimulated some herd immunity with our vaccine program over the last, half a century.
When enough of us have had it, then the virus can't get back into the population at a high level. And so absolutely correct, by either exposing ourselves to it over time or getting those numbers up even a little more by vaccinating another percentage of the population, then we can get the population to, usually it's around 80%.
But viruses, to my understanding, like bacteria, change with time. Do you see this one changing and becoming harder to detect and in years to come?
You're absolutely right. Viruses do change over time. And RNA, this type of virus is an RNA virus. Those tend to mutate, and it makes it harder to vaccinate against, to be quite honest. And that's where herd immunity is probably going to be important. This particular virus has already mutated 3 major times around the world, at least 14 submutations. We have an S subtype and an L subtype, and those that get the S seem to be doing better, and those that get the L seem to be getting sicker. So we've already seen this virus mutate, and over time, a lot of viruses go away because they acquire a mutation, and then they just become like a common cold. But at the same time, you have to consider sometimes they can acquire a mutation that can make them more aggressive.
So, Dr. Cole, before we end, would you mind talking about potentially who should be tested, how the decision should be made to be tested, and what should be done with the results?
Who should be tested? Well, ideally, we really want to know how many people in the population have had the disease. And if we want to do that, pretty much everybody eventually should be tested. The ability for the laboratories to keep up with that volume is obviously a challenge. We can only do so many a day in our setting here, and I know around the country the availability of testing is very variable right now. If you're acutely ill and potentially could end up in the hospital, obviously those patients need to be tested. In terms of if one has gone through the illness and wants to figure out, have they developed a point of immunity, that's where the blood, the serology, the antibody testing becomes important. I think that helps, societally too, with anxiety, when we do realize through that antibody testing that more people have had it than we thought. So there are 2 approaches, and I think they're both useful in terms of clearing the population and knowing and understanding the breadth of this disease. And so, it's a good question. Who should be tested? Ideally, everybody. It's just a matter of the availability and over time and the practicality of doing so.
My concern is that when it comes to testing and potentially populations or everybody, is that the data could be used in a non-benign way and potentially could, not only differentiate, but people could hold it against you. If you have an antibody or you don't have an antibody, you can work, you can't work. There are certain assumptions that we all make in a society that everybody is out to do the right thing, or at least what serves them. And unfortunately, if you go testing everybody and you have an app on your phone or a card, or you have to wear something on you, potentially there could be discrimination and other psychosocial issues that become political rather quickly.
You are absolutely correct, and that is a big can of worms. And I think that's where the doctor-patient relationship is important. I think, the best interest both of the individual involved as well as, the societal implications. And that's, and that's the challenge. And interestingly, in the history of humankind, we've never quarantined the well. We always quarantine the sick. And that's where the doctor-patient relationship is important. If we understand the status of individuals who've been sick and we know their underlying illnesses, then you as the doctor can help that patient in the best way possible to keep them safe. In terms of so much of this population, in terms of the data I've seen so far from my patient group, we know how many people have had it and have gotten through it just fine. So I think it's interesting to know who's really those risk populations and how can the doctor-patient relationship keep our society functional, not the government-patient relationship.
Thank you. I appreciate you clearing that up because, there's, I guess, lies, damn lies, and statistics. Some say that figures don't lie, but liars can figure. So you talk about weeds. I guess we could spend a few more half hours discussing these sorts of things. Can you give people contact information or whatever you'd like to share?
Yeah, certainly. I can be reached at colediagnostics.com. I'm a regional laboratory where I am. I do see patients from coast to coast and work with doctors from Maine to California, and I do a lot of consultation work. I've actually been in touch with probably about 500 to 1,000 doctors over the last couple of weeks because of a couple videos I put out. So I'm hard to get hold of these days, but if you do have questions for the laboratory, colediagnostics.com. So thank you for that opportunity, Dr. Wax.
Sure, and thank you for all of the efforts that you're doing and sharing your results with the world. Thank you again, Dr. Cole.
Thank you, Dr. Wax. It's an honor being with you, and I'm happy to answer any questions going forward, and look forward to chatting again sometime. You stay well there on the East Coast, and we'll enjoy the mountains out here for you.
Take good care of yourself. You've only got one. Remember, health is number one. Here's your Dr. Wax fist bump. For this and more information, you can go to healthisnumber1.com. You can also Twitter with us at the @ Dr. Craig Wax, DrCraigWax, and the same at Instagram and on Facebook as well.